Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Joseph Eron. I'm a professor of medicine at the University of North Carolina in Chapel Hill. Welcome to Clinical Clips from IDWeek 2024. This is day 2 of 2. We have some really exciting information to present to you today, so I'm going to just jump right in. The first, there are actually 2 presentations that were very similar, which were looking at mortality across the U.S. population, mortality due to HIV. And what they look at is something called AIDS-adjusted mortality rate. And there were 2 different populations that were looked at. So this is not mortality predictions in people that have HIV. This is looking across the U.S. population and seeing what proportion of deaths were related to HIV, and then adjusting that for the age of the person in the population that we're looking at. So the first one are among reproductive aged women in the United States. And this is all based on something called the CDC Wonder database, which collects population-based mortality. It's really important that we know that this is population-based mortality based on death certificates. And over that period of time, the deaths in that population that were related to HIV dropped by 5-fold. Which is a good thing. And there are a couple of other interesting things in these data. One is that in the beginning, most of the deaths related to HIV in these younger women were in urban areas. But over the last 3 or 4 years, actually the proportion of deaths that are due to HIV in women of reproductive potential and actually are almost the same between urban and rural areas when you look at age-adjusted mortality. And then the other thing of interest was that the deaths during this period were highest in women in this age group in the Northeast, but then in the South. So that was looking at women in this kind of relatively small age group, 15 to 44. What if we look across the whole U.S. population? So again, this is looking at mortality from HIV across the U.S. population. And this data set was from the CDC, so it was a little bit more current. It went from the 1999 to 2023. And in that time period, there were 270,000 deaths in the United States that were felt to be related to HIV, right? So this is not people known to have HIV and cause of death. This is in all people in the United States, 270,000 of them died from an HIV related cause. Not surprisingly, the age-related mortality is consistently about 3 times higher in men than in women. And what's of all the AIDS deaths in the United States, 52% have been in people of African descent or Blacks, which is really just a stunning statistic since they're a much, much smaller percentage of our population. 33% were in whites and then 13% were in Hispanics. And if you look, it's interesting, most of the deaths over this very long period were in about 50% were between the ages of 45 and 64. And the one group where the age-adjusted mortality related to HIV is going up, you might say, oh, that sounds bad, is actually people 65 and older. But I don't think that's bad. What that means is people with HIV are living to be even greater than 65. And again, these are death certificate death certificate AIDS causes. So the fact that that's going up a little bit over time just means there's more people with HIV who are living beyond age 65. So, and then unfortunately, 50% of the deaths from HIV-related causes in the United States occur in the South. So there's a lot of data in this presentation. I've kind of summarized it. Really, the main issue is that HIV, the proportion of deaths in the United States related to HIV has decreased dramatically. But unfortunately, Blacks and people in the South are contributing, unfortunately, more HIV-related deaths than their proportion in the population. So now I'm going to move on to long-acting PrEP. There were two really nice presentations from a couple of large cohorts in the United States. One is the TRIO cohort that gathers data from 12 health clinics across the U.S. That focus on HIV and HIV prevention in addition to having primary care. Remember, long-acting CAB was approved in December 2021. And this particular population where they were able to get data on actual injections using specific codes for the injections, they had data on 526 people, and 474 of those had 2 or more injections. Most were men, but actually the majority, 52%, were people of color, which I think was terrific for this group, though most had commercial insurance, which I think is not surprising. And about a third of the people who were getting more than one injection had delays, though the median delay was about 12 days. And then when we look at kind of HIV screening, only 34% of people had both HIV RNA and fourth-gen sequencing with all their injections. So the kind of standard screening is mostly by antigen antibody. There certainly are plenty of RNAs being done, but not, following CDC guidance. There was no serious liver injury, no hypersensitivity reactions, and no seroconversions in this group. The second one was the OPERA cohort. The OPERA cohort actually serves 850,000 people without HIV, and over the period of time that the OPERA cohort has been functioning, 53,000 have ever received PrEP, and since December they had about a little over 18,000 PrEP prescriptions. And similar to the TRIO group, they had 764 prescriptions for long-acting cabotegravir. They had a little bit more data. Of those 764, 75% had commercial insurance, only 13% were women, and only 29% were Black. And of those 764, 85% initiated on time. Of the people who started with 2 injections, 69% had got them on time and got them all on time. But the delays were relatively short, if there were delays. In OPERA, only 65% of those who started CAB LA had a HIV testing within a week of starting. Now, they may have had recent HIV testing, and then only 50% had any HIV testing at all injection visits, right? And smaller proportion, much like in the other cohort, had HIV RNA testing. So I think that the news here is that we're getting long-acting CAB out and into the community and practices. It's well tolerated and it's quite effective, though the screening is really not happening as recommended by the CDC. But I think the screening is consistent with what we see in our much smaller practice. So those are the basic messages here. Very safe, very effective, but certainly less HIV RNAs being done with injections. In our final study, It's a combination of islatravir, which is a drug that's in development that inhibits the reverse transcriptase, and lenacapavir, which is a drug that you all know that is used in highly treatment experienced people and given as an injection. But this is an oral therapy with these two drugs given once weekly. So it's our first once weekly therapy that's under studies. And in this particular study, this is a phase 2 study. So there were 104 participants, randomized. They were all people that were on BF-TAF, and they were randomized 1-to-1 in an open label study to stay on their BF-TAF or go to this once weekly therapy. The results here are very straightforward. At 48 weeks, 94% and 92% of people either on islatravir, lenacapavir, or BF-TAF had HIV RNA below 50 copies. Nobody had an HIV RNA above 50 copies. There were no grade 3 or grade 4 laboratory events, except in one patient who acquired hepatitis B and had elevated LFTs. And then if you looked at this lymphocyte counts over time and CD4 cell counts over time, there really were remarkably similar between the two arms, and there was no significant difference. So that's my summary. Thank you for joining us for this series from the 2024 IDWeek conference. Please refer to the landing page for the slides and to claim your continuing education credit, as well as looking at the previous clip, if you haven't, from our first presentation from a couple days ago. Thank you very much.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.